again, today we're going to talk about circumstances of fatal overdose in the state unintentional drug overdose reporting system.
AKA suitors.
Yes.
Mary was on, I don't know, it was a month or so ago. Time and me just don't get along anymore. And so much good information. We had such a great conversation. We thought we need more and continue our great conversation.
All right. So remember, there is free CME. It is still free. You can get it every week. So please just make sure.
That joke has been going on for 4 years and it's never been funny.
Yeah. And so please just make sure you fill out the thing so that you can get the free and CME.
And please turn on your videos, as I said. And if there's more than one person in your room, please chat that to us.
Coming up next week, next Wednesday, Drew McNamara and myself, he's a PA student who did his master's paper on schizophrenia and substance use disorders. We have a really nice talk for that. Should be fun with a couple of built-in cases, so that should be great. Again, on the Tuesday one, we're doing perioperative management for those of you who want to pop in on Tuesday.
If you can't get on the Tuesday one but want to hear this, please let us know, because that might be what fills the 27th, just because it's one of those topics that the last time we had it on the Echo was prior to all the newer recommendations and data. So yeah, we get these questions a lot as more people are doing MAT in their communities. And so this is definitely coming up, but you can see the list.
Yep. Again, if you need technical assistance, please reach out to us. Erin's number's on there as well. Our RN, she's not on today because she has a different meeting. But yeah, our phone numbers, please just give us a call if you have any questions.
Oops. Okay, I didn't do it. Oh, I keep trying to control it. It's Katie. So the online resources site, please check it out. It's got Echo registrations. It's going to have all the paperwork. We are working our way through that actually very diligently. So any of the paperwork y'all got in the past or you want from our manuals, this is going to be the online resource manual. So the easier version than the big book.
And we are painfully redoing it all. So it's been a lot of work.
It's really painful because Kurt is neurotic.
Yeah. So next slide.
I left this in here.
Oh.
If you have a case, there's multiple ways, let us know, but it is on that website. It's actually easy to find. You can do it digitally. It's a way easier form. Otherwise, just let us know if you have one and you just want to, like, med student, give us the verbal update on a case. We can walk through it with y'all.
All right. Remember the Addiction Connection podcast. I have no idea what came out this week.
This was our random one we were doing with Charlie, and it just kind of organically happened. It is actually on the conversion from methadone to buprenorphine products. Super cool conversation, and the ins and outs of how to do it, why you do it, and what is the bad things about transitioning a patient from methadone to buprenorphine.
Yeah, frankly, I can't remember any of it. I probably got to listen to it. Okay, next. Again, the objectives for today, we'll put up there for a moment. Otherwise, we'll let Mary introduce herself and tell us a little bit about what she does at the state. So
and share your slides, Mary, as you're ready and able. And if people have questions, of course, throughout, we can definitely facilitate that. And otherwise, you can unmute, raise your hand, or do all the things we all know how to do on Zoom now.
Hi, everyone. I'm Mary DeLaQuille, and I'm one of the overdose epidemiologists at the Minnesota Department of Health in the Injury and Violence Prevention section. I was here in May talking to you about the 2021 preliminary overdose data. And now we're still going to be talking about overdose data, but it's going to be different, a different timing for one thing. But I'm really happy to be here, mostly because I have been waiting to have enough information to talk about suitors publicly, to have a big enough N, basically. And so you are my first, I won't call you guinea pigs, but you're my first group to get to hear like a presentation just about suitors, not where suitors is part of it, but and I just say, ooh, this will be interesting when I can do this kind of thing. So thank you so much.
No, we feel really honored. I mean, because ORAC hasn't even gotten this yet.
I'm telling you, you guys are first. Yeah. So I told ORAC to wait until September. So yeah, because there will be more data then. And you know, if you want me back sometime in the autumn, I could certainly do that with the update. It just depends on how helpful it is for you all.
Perfect.
So what is suitors? Are we going to advance myself? There we go. So It's an acronym that I did not make up. The CDC did. If it's too generic for you to remember, like it is for me, it's not my fault. It has been active in Minnesota since July 2017. Don't ask me why it started in the middle of the year. It's just one of those CDC things. And at that time, it was opioid-involved overdoses only. So that was one of the reasons why I was not getting a big enough N to talk about. And it wasn't until 2019 that we started doing all overdoses and getting a way more complete picture. And from 2016, 2017, with the growth of fentanyl usage, the opioid-involved cases proportion has been growing and growing and growing. So I think currently we're standing at about, for 2021, 87% of the cases statewide involved in opioid. So its purpose is to provide overdose mortality data to assist data-driven prevention efforts. It includes de-identified case-level data on all current overdose deaths in Minnesota. We don't care what resident of state they were. Did they die in Minnesota? Then they're here. So that makes it hard sometimes when we're talking about trends going back. If in public health, we're frequently talking about residents, right? But SOAR's being its own system, it's always been a current. And that's the same thing with the National Violent Death Reporting System, which is its sister system. They're both in the same system run by the CDC, and many other things are too. Some of you might use SAMs for other projects with the CDC. And there's actually some shared deaths between the two systems. If it's of undetermined intent and they died of a drug toxicity, they could, and there's potential it was a suicide or unintentional, then they are shared by those two systems. We have a new SOAR's landing page. There's the link. Annika and the communications team, some of whom are on this call, many, many thanks to them for getting it live today, just for this presentation. There's the link, and I can send it to Katie to share an email too. I know how hard it is sometimes to, and the presentation I sent you last week did not have the link because I still didn't have the link ready. So there we go. That's what's going on in general with what SOAR's is. So why do we go to all this effort? And let's not kill ourselves. I have abstractors abstracting each case individually, and it's quite a bit of effort. And this is why we're going, one of the reasons, I mean, the CDC is, we have a grant and it's a grant deliverable, but this is also one of the reasons I may have shared this slide in May. I can't remember, but we're slated in 2021 for overdose poisoning injury deaths to overtake all other injury type deaths in the state, even though falls and 100% alcohol attributable deaths will not be going down. It's just that overdoses are increasing more rapidly. So for me, that's one of the main reasons why we go to this effort, is because this isn't going away in Minnesota. And I'm pretty sure all of you here know that. So this is what SOAR's is striving to do. How well it does it is really dependent on the data. It strives to just gather a lot of variables on each and every overdose death. There's over 600 potential variables that we can gather. For SOAR's, most of the data is coming from either the death certificate, from the medical examiner coroner reports. And when I say report, I mean, if they're doing an investigation, there could potentially be a lot of stuff in there: scene findings, the autopsy, EMS records, medical history, toxicology findings. And if there is a law enforcement report available, we will abstract from that as well, although that is not always the case, especially for metro deaths, that there won't be a law enforcement report available. And it's all entered into the SAMS CDC platform. Here's some of the overall goals of suitors: to understand the circumstances that surround overdose deaths, to improve the timeliness and accuracy of data, and to identify specific substances causing or contributing to overdose deaths, such as xylazine. Pretty sure everyone's heard about that one here. So I know recently, I believe it was in October 2020, 2021, the medical examiners started noting xylazine on the death certificate. But before that, we did not, it wasn't being noted on the death certificate because that isn't the cause of death. And the only way I could find out if xylazine was present in fatalities in Minnesota was to go back and look at suitors' cases. And yes, if anyone's wondering, xylazine is present in Minnesota. It's increasing exponentially. So there was 4 in 2019, 8 in 2020, 23 in 2021. And the last time I looked in 2022, for the first 3 or 4 months, there was already 13. So it's here. And that's true of other drugs that HIDA in particular asked me about, as in, are we seeing these in fatality yet? I can't think of some of them off the top of my head, but when they see alerts saying, is this drug in Minnesota yet? They come to me, and I frequently look in suitors because that's where I will usually find it. So now we're going to just start talking about the interesting things that we have been finding in suitors. One of the things I think is most interesting is the points for intervention previous to the death. Were they recently released from an institution? That could be a correctional facility or inpatient treatment or something like that. Did they have a prior overdose? Did they have a mental health condition? Have they ever been treated for substance use? Was there a bystander present? Was the drug use witnessed? And you can see that 80% of the suitors' deaths did have at least 1 point for intervention prior to the death.
Mary, can I just ask a question really quickly about that?
Absolutely. Yep.
I know release from institution is one thing, but does it ever get looked at as when and how, or when, an ER visit? Whether it was for, a skin infection or an overdose, or coming in and saying, I want to stop using drugs, because we see that on, post ER release, and, the provider says, don't use heroin. And that is literally their ER visit. Mm-hmm. Is that ever looked at? Like within the last 6 months, patient had a touch point in an emergency department or even in a clinic?
Yes. So all this data that we're looking at today is from 2019. So sometime, and the CDC adds new variables all the time, and they're not very scheduled. But I know we currently have a variable now that I believe we did not have in 2019, or it was ticked so infrequently that it didn't make this chart. But I believe we didn't have it in 2019 about previous emergency department visits. So that will be getting tracked in the future. So stay tuned, because my next suitors analysis will include both 2020 and 2021. So hopefully we'll have more of that. This is as good a time as any to say that the person might have visited the emergency department multiple times before their death, but it might not be in the death investigation record. It really depends on how busy the ME office is. It depends if the person they're asking knows if the person went to the ED. It depends whether they were able to get medical records to look at. It just depends on so many things. So I don't want anyone to ever assume that this data is some kind of gold standard data. We abstract the data that we have, but that doesn't mean that these numbers could be much, much greater. I have on a later slide, I had a note to tell the story. I'll tell it right now. I was in a fatality review on a suitor's death because it was an overdose, and we had no record that they ever had a prior overdose. They had 6 prior overdoses, but they weren't in suitors because we didn't know about them. And as any of you who's been involved in a case level fatality review, you can get a whole heck of a lot of information from a fatality review. So
So do you guys review those the same way like we do on the maternal morbidity review committee, where they like MDH puts out this request to like all medical records, all of that? So then when you sit at this table, you really can review all that, or no?
No, so I mean, it is similar, but currently the way overdose fatality reviews are being done, and it's under the prevention side of the grant under Dana Farley, and I know a bunch of his people are here. We partner with local public health or community partners to do fatality reviews on those subpopulations. Whatever they're like, we have a very strong group in the north. I'm not from Minnesota. I have to think about this. In the northeast corner of the state, we have a very strong group in Rice County. We have a couple, there's a strong tribal nation group that's doing it. There's a Somali, the Alliance Wellness Center who's doing it. I think it's Somali, if I'm remembering correctly. So we're assisting, we're partnering with them, but they are taking the lead of those fatality reviews. And people like Pearl Evans, who may or may not be on today, I'm not sure, would be able to give you more information specifically about what's going on with the overdose fatality reviews currently here in Minnesota. And I'm involved by providing data, but not involved in like the running of the fatality reviews or the grant / funding. So I don't know all those details.
Just because, I mean, when we sit down and MDH has requested all those records, that's where you find, man, this person was in the ER at this time, or they did have this contact point and now they got beat up by the boyfriend they told about in the ER and now they're dead. Like that's, so it'd be helpful, I think, especially moving forward as getting MAT and MOUD into the ERs is becoming a push to have that data. Anyway, I'll talk to Dana.
Yeah, absolutely. So, I mean, I am invited to some of the fatality reviews as well as providing data. And I will say, there's frequently hospital people. I mean, I've been in some fatality reviews where somebody there had talked to the person's high school counselor and the decedent was 31 years old. I mean, the amount of data they had on that person was kind of stunning to me. And then their parole officer, and it really depends on the group and the access that they have to that person's life. And of course, it makes a big difference if the person didn't just die in Minnesota, but they grew up and lived in Minnesota. I mean, there's all kinds of things that can affect that. But the fatality reviews currently are being it's a national effort and there's a national system. So Minnesota isn't just making it up. So they're trying to collect data systematically, nationally on fatality reviews so they can draw conclusions nationally as well as in specific communities. And of course, they do talk about all these things, which is, what happened, where were those intervention points, basically. So Suitors has access to almost always to the complete toxicology testing that is done by the medical examiner. And if they were in the hospital, we frequently will have that too. And we put it all in. If they had nicotine in their system, we put it in there. If they had caffeine in their system, we put it in there. If there's a positive hit, we put it in there. So, and on this graph by all opioid, we actually need any opioid. So any opioid. And this is just because we're interested in what's going on with fentanyl. This is the proportion of deaths where fentanyl, which we frequently call the synthetic opioid, but pretty much everyone here probably knows that means fentanyl. And what proportion of these other categories of deaths had fentanyl on board?
So when you say commonly prescribed, I'm just thinking like all my patients who say I smoked 15 Perk 30s a day, they know that that's not actually Percocet. They know that that's straight fentanyl. They're buying it on the street, but they're still calling it Percocet. So is that under the commonly prescribed opioids? Because it's technically.
Yeah, that's a great question. And I'm going to say, I think Suitors could do a way better job at, maybe they couldn't do a better job. I would take anything that says prescribed opioids with a grain of salt, basically, Because when I look at the actual data system, if the ME has access to the PMP, if they had a prescription for something, then we could say, okay, yeah, so that's probably was a prescribed drug of whatever kind. But, and then there's other drugs like, if they had pill bottles on the scene for Adderall or something like that, then, the stimulant that they had was probably prescribed, things like that. But there's really, this is not gold standard. I can't say, we're just lumping together the commonly prescribed drugs as opposed to, which we do not consider fentanyl commonly prescribed. If fentanyl came back on the toxicology test, we pretty much always assume it's illicit. So again, this is toxicology testing. So it's not self-report, right? It's not people saying, oh, I'm taking Percocet, I'm buying it on the street and we know it's really fentanyl. I mean, if they had fentanyl on board, it's there, right? So, and if they had, I have no idea what Percocet breaks down to. Is it codeine and Tylenol? I can't remember. You can tell I'm not a forensic toxicologist. But I'm sorry, go ahead.
Tylenol and oxy are the two components.
Oxy, thank you. So, I mean, depending on when the testing's done, they could actually, the toxicology test could be specific for oxycodone. And then if they actually had acetaminophen on the toxicology testing, and there was some kind of thing in the investigation saying that they have been prescribed Percocet in the past or blah, 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 then it probably would have gone into the commonly prescribed bucket. Because all, the indications were all, okay, yeah, that it's very likely that there was a prescription around. I mean, of course, they're never going to catch everyone who has, who's borrowing someone else's prescription or taking someone else's prescription in the house, or, I mean, there's just so many variables, but, we try to investigate that as much as we can.
And that testing is done where, and is this the information's from death certificates? So if the ME sent
No, there is information from death certificates and suitors, but the toxicology testing is actually coming from the toxicology results. And virtually all the MEs in Minnesota are using NMS testing.
Okay, thanks.
Sure. I won't say it's going to be 100%, but it's very consistent. So, and they're doing, I can't remember what it's called, but like not advanced, a large testing, because they are looking for novel drugs of interest when they're doing testing on overdose deaths. So this is a similar chart, and this is just showing instead of fentanyl, we're looking at meth and the proportion where meth is occurring with other drug categories. And again, all opioid is any opioid. So, and like, there could be questions like, so you actually have heroin here. And when we have heroin, we mean that 6 ma'am was on the toxicology. We don't assume this, again, this is not self-reported heroin.
Sorry, one more. These categories are not exclusive then, if I'm using the right term. So if there's more than one thing found, it's reported under each section here, right?
Right. So if there was a death with meth on board and it had heroin and it had cocaine and benzos, it would be in all 3 of those. Correct.
Thanks.
Yeah. And we're showing proportions, not case numbers here. So. So now we're going to jump to talking about where the overdoses are occurring. These are fatal overdoses. Again, we're only talking about fatalities here, and we're only talking about 2019. And so this is all pre-COVID data. But the vast majority where we had a location, they were occurring in a residence, near a residence, in the driveway, in the porch, in the yard. Which much smaller proportions happening other places. And then unfortunately, a fairly sizable other unknown category where we just didn't have the information in the record. So it might be that the person, although that's, I think, too high of a number for them all to have died in the hospital. A lot of the time, if somebody dies in the hospital of an overdose, we lose some of that, what happened immediately preceding to the death information.
I would add to this, and it might be under the other, or, just looking forward, is add incarceration, because you'd think that once they get incarcerated, then they're going down. But I can give you a handful of incidences where someone died in some type of facility where they were incarcerated and they'd already been in 2 weeks and they still overdosed and died.
Mm-hmm.
I think that's a huge, the facilities look at that because the drugs had to get in somehow, but that's always an interesting one to me.
Right. So, that is a variable that we can choose, but apparently it wasn't coming up in a meaningful way in the 2019 data. And a lot of times it's very hard with both violent deaths like suicide and overdose deaths to get whether the injury or the death happened in a facility. I think everyone kind of knows that sometimes, depending on the jurisdiction, that can kind of they're like, well, they died in the EMS vehicle. They didn't die in the, so things can get kind of, I've noticed things can get kind of muddy with that category, I guess is what I'm saying. So, but hopefully, like I said, in the next round of analyses with 3 years, we'll be able to get more granular and have more. So fingers crossed. And unfortunately, we certainly have more deaths that will be, compared to 2019, we had, way more overdose deaths in 2020 and again in 2021. So Suitors has a variable where they're saying, what was this death attributed to, basically? There are very small proportions, you can see from this pie chart, where somebody just unintentionally took the wrong amount of their drug that they were prescribed, or someone was over-medicated, or there was some kind of weird other unknown thing that we just couldn't quite nail down what was going on. But the vast majority of the deaths, 85% of them, are directly related to substance abuse /use. So the substance abuse wording is coming from the CDC. So that is not my choice. And I didn't catch it because I'm so used to seeing substance use.
On that last slide, so how are the intentional exposures pulled out? As you know, there's some question about somebody who's misusing an illicit substance, but is there some intentional sometimes?
So you're asking about manner of death now?
Yes.
Yes. So for the most part, we assume that what the ME put as manner of death as accurate, because they're the ones who did the investigation, and they do have a category, as you all know, called undetermined, where if they're not sure if it was a suicide or unintentional, that they can choose the undetermined category. And undetermined deaths are included in Suitors for that reason, because they may have been accidental, they may not have been. So, undetermined poisoning deaths, not undetermined knifing deaths or something like that. That's not part of an overdose data set. So if the abstractor is reading the case and their very strong take on it is different from what the death certificate / medical examiner is saying, we have a place to track that data and to put it in there, but it just really happens rarely. Our medical examiners and coroners are good at what they do, and they have a lot of experience, and they think about it a lot. I will say, there's a lot of discussion, Beth, about suicide by overdose and accidental overdoses. I've had some people say, like in the communities, say these are deaths by suicide. and sometimes they say because this person didn't care whether they lived or died. So they think of it as a suicide. I've also had addiction experts, some of which are probably on this call, tell me that it's very unlikely for someone who's a substance user to choose their substances as a way to suicide. This is not my area of expertise, and I'm not going to weigh in on if there's one right way to think about it. I just know that people think about it in different ways, and different experts think about it in different ways is what I'm going to say. Any questions about this slide before I move on? So here we're just looking at routes of administration, and there's different levels of evidence, but they're all collapsed into this chart. So I mean, when we say there was that injection was most common, the needle could actually still be in them when they were found. The needle could be beside them. There could be track marks. There could, there's different signs that we would put it into this bucket. There's also report, if somebody said, yeah, my friend was snorting, blah, 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 or if there's a pipe or, just foil, just various things that put it into different buckets. And then as you can see, almost 1 in 5 where we don't know the route of administration. And frequently that will be a death that happened in a residence and the scene was cleaned up before anyone ever got there. So nobody really knows. And there isn't anything obvious, any obvious autopsy finding either. And then you can see about 1 in 5 again have more than one route. Again, and that could be based on the physical evidence, either of the scene or of the body or a report or, any combination thereof. So yeah, we talked about this. We're always interested, did they have previous overdoses in the timing of that? So 56% in 2019 had a fatal overdose in the past year before death. 17% had a previous overdose, but it was more than a year before the death. And then 27% is just in that unknown bucket. And again, like I said earlier, I can't tell you what that unknown means, except that we just don't know. It could mean they had 6 overdoses. It could mean they overdosed the week before they died, but we just wasn't in the record. It could mean that nobody had any idea they were using substances and they had never overdosed previously. So some of the circumstances we try to collect are mental health conditions. And so there's a lot of variables about mental health, diagnoses, and all kinds of things. If the information's there, which it is not always there, I will say, but sometimes it is. And this is what we collected from the 2019 data. So I don't think any of this is surprise. I did not prep all these slides myself. I had a research analyst last year who did it for me, which was super awesome. And so I don't have a note here. Sorry about that. So I believe in 2019, there was 600 some deaths as part of this data set. And I don't know the proportion that had any mental health condition noted, but I would say that it would be no more than half. So a lot of times with overdose deaths, we do not get mental health information. Now, whether that means there just isn't any or whether it just wasn't found, I don't know. And that's just a very different contrast for me about violent deaths. In violent deaths, we frequently get mental health information. So suitors, I think it was sometime let's see, n equals 439 decedents. So it might be that this variable was added at some point in 2019. I can't say, I don't have a change log for suitors for the different times they added the variables, but they just noted common medical conditions. And here's the percentage. So, about 2/3 of the cases had some kind of noted medical condition. And these are the results, with the most common being obesity and other chronic pain. And when we note these common medical conditions, it's coming from a medical record or some other record in the file. It's not judgment. It's not judgment on the abstractor's part, I guess is what I'm trying to say. Somewhere in the record, they said one of these things. So, just to kind of sum up the kind of things that we've been talking about here, 85% of them were related to substance use, and a very small number of deaths were due to other factors like over-medication or unintentionally taking the wrong drug or unintentionally taking a drug at all. I mean, that could happen with a child. The large majority of them occurred in or near some kind of residence. A bystander was present for over half of the drug overdose deaths. An interesting, slightly problematic thing about the bystander definition in this system is that they count anyone 11 years and older a bystander. So I just want to put that out there. You may or may not have opinions about whether an 11-year-old could intervene in someone's overdose and call 911 or administer naloxone. I'm sure some 11-year-olds can. But I do think that's a very young age to set the bystander limit, but that's where it is. So
can I ask a question with that?
Absolutely.
If this is looked at maybe more to the future of the bystander present, what percentage of them did call 911? What percentage of those individuals who did end up passing did have Narcan given to them?
Right.
I would think that would be more dramatic with the Narcan and still overdose more now with the fentanyl, but I would be interested, and as I'm sure the Rumler Foundation, who does all the, especially Steve's Law stuff, with what percentage of them actually were called.
Yes.
So
they've added a bunch of variables tracking naloxone amounts, who administered, whether it was some kind of first responder, whether it was a lay person. And again, see, this is only 1 year's worth of data, which is one of the reasons why I've been holding off until I've gotten more years, so that I could break things down to say, here are the bystanders. And these bystanders were a family member, a friend, a significant partner, or a literal stranger. And here's the percentage of them that were able, that administered naloxone before first responders came, things like that. We should be able to get more of that detail when we have 3 full years to look at. Although, again, like I said, they do add, and also number of dosages, because as we know, in a lot of cases, larger amounts of fentanyl have been needed to reverse successfully. So we are gathering more of that information, and it is going into this system, but there wasn't enough. In fact, a bunch of those variables might not have existed in 2019, but they are there now. So hopefully, again, I feel like I'm teasing you all by saying we should have it, and fingers crossed that we will. So, but yeah, we and everyone else are very interested in naloxone distribution. Is it getting used? How's it getting used? Who's using it? And all those other things. So we're trying to find out. And then we're even more interested, not even more, but we're also interested in how's it getting used for people who aren't dying, right? But that's I'm the mortality epi, so that's not on my plate. And let's, the other 2 notes was that 1 out of 10 decedents have been recently released from an institutionalized setting, most commonly from the hospital or from jail, prison. So some medical and social history findings that 4 out of 5 decedents had a history of non-alcohol substance misuse. We do track alcohol misuse as well, but that's a separate variable. 1 out of 3 decedents had previously received some sort of treatment for their substance use. About 20% had evidence of a previous overdose. Over a third had a known mental health condition. And a common medical condition perhaps contributing to substance use was chronic pain.
Okay, so.
No, that's fine.
What percentage, you said 1 in 3 had previously received treatment. Is it looked at, like you talked about the co-ingested substances, whether it's benzos, opioids, or whatever, do they ever look at what percentage or what numbers had methadone from like an OTP on board, or like buprenorphine products? Because I had a patient overdose. Luckily, he got the Narcan, but he had buprenorphine on board. It's just fentanyl overtook it. So that would be interesting to me too, like who's actually in potentially treatment. But then you'd have to break it down into who's taking the Suboxone or the methadone from a provider or from the streets.
Right. Yeah. So there is a variable when we ask about treatment, it does break it down to, are they currently in treatment or did they have previous treatment? Was it an MAT type of treatment? Was it cognitive behavioral therapy treatment? A couple other things that I can't remember off the top of my head, but they are breaking it down into subcategories. And then, of course, the MEs do have access to the PMP. It almost always gets pulled, and they look for prescriptions to MAT drugs. So, because as you said, they could have Suboxone on board, but that doesn't mean that they're getting MAT necessarily, right? So, again, I'm so sorry to sound like a broken record. Hopefully, when we have more data, and a lot of those variables, like the treatment, the different types of treatment variables got added later. So I don't even think in 2019 they were available. It was more just like, did they have a history of treatment? Period. Yes, no, at that time. But they did get more granular currently.
Another push to get methadone on the PMP. Because that's not on the PMP if they're getting it for treatment at a methadone clinic. That methadone will not show up on the PMP.
Okay, yeah, I'm not. So
no, this is just me. I know there's people from the state on here that just, this is one of them.
So I don't work with the pharmacy board, and I actually didn't know that. And, we here at MDH in my group, we don't actually have access to the PMP. So we just were getting the information from, it's either in the, through the ME, basically. So that's very interesting to know. So Suboxone shows up on the PMP, but not meth.
Correct.
I mean, not meth. Listen to me, sorry.
Yeah, if somebody gets Suboxone from an OTP, though, from a methadone clinic, then it won't show up. So medications provided from an opioid treatment program.
I
so
see what you're saying.
Not show up because it's protected under the CFR, whatever law. So, yeah.
I see what you're saying. So it depends on where they're getting their MAT, basically, from.
And the majority of people getting Suboxone or buprenorphine products are getting it from not from an OTP. So a majority are going to show up on the PMP. My bigger issue is the methadone, because it's much easier to overdose with anything while on methadone versus the Suboxone. So, so many deaths are attributed to also being on the methadone. So, we'll put Beth Bilden on that task right there.
Yeah. So I will say again, since we're getting the complete toxicology test, and please, you guys, you have my email. You'll see my email again in a couple of slides. Send me these ideas and these notes, because if they had methadone on board, it's going to show up in the toxicology testing. I might not know where they got it. I might not know if they were getting it through a clinic. I might not know any of those things, but I at least know if it was there. And, we can look at the subcategories of toxicology testing that are of interest for various reasons, even if the reason is we would really like to somehow get this information on the PMP, or we would somehow like to get, whatever. I mean, there could be all kinds of reasons. Or like, what you were saying, Heather, I think it was Heather that was talking, sorry, that the pictures and stuff are so small. If it's easier to overdose if you're on meth methadone, MAT, as opposed to Suboxone, I mean, that's an interesting prevention point for the prevention team, and they would probably like data to show how often is this happening, where in the state is this happening, or things like that. So. So just again, to just kind of wrap up, in 2019, more than 97% of all overdose deaths occurring in Minnesota have been reported into suitors. The vast majority of the ones that have not been reported into suitors are the people who are dying no, let me rephrase that. They're the people who are going through the North Dakota Medical Examiner's Office. And we have had a lot of problems getting data records from them over the past few years. So it's not a large number of cases, maybe around 20 a year, but we're missing that data in that area from that medical examiner's office. Deaths are driven by synthetic opioids, by which we mean fentanyl, and psychostimulants, by which we mean meth.
Could you speak to that a little bit more in terms of separating? My understanding, or when I'd asked, was that the psychostimulant deaths, and specifically methamphetamine toxicity, that death is very different from an opioid-related death.
Mm-hmm.
And that my understanding is what's being driven is the combination, and it appears more. You know what I mean? It's still opioid related, as opposed to separating the two out. Am I understanding that correctly? And could you speak to that?
I mean, I can speak to definitely this general toxicology testing is confirming that polysubstance use is growing. It commonly involves fentanyl and it commonly involves meth, right? So it's very statewide, and I don't have the number in front of me, but a large proportion of deaths have both fentanyl and meth on board. And this is why we're saying this is what's driving the deaths. And I don't have this slide here. It was in my previous presentation where I have it broken down by the non-exclusive drug categories. And we see the all opioid line going up. We see the synthetic line going up, almost running in parallel, but we also see the sharp increase in the methamphetamine line. So that's why we're saying those are the two things that are driving our overall death totals. And because polysubstance use is growing, it's the majority of the deaths. Like I said, I believe it's about 87%. And I can't tell you, but a great proportion of them have some kind of opioid on board, more likely fentanyl and methamphetamine. So it's just it's a statewide thing, and it's also Minnesota's mirroring what's happening nationally. Does that help, Beth? I'm not sure. We can always take this off and get more. We can dive more specific if you want.
I think for those of us in the audience today, the point is that there's a lot of polysubstance use.
Yes,
and that's really the takeaway, that it is hard to say. The other part of that is methamphetamine may stick around a little bit longer in certain cases. And is that there's so many factors that it's difficult to separate and find specifically methamphetamine death.
Right. I mean, now those do happen. There are some deaths where the complete toxicology testing is done and only meth is found.
Yeah,
and those small proportion. And
those are going to be based a number of those on the history that the patient was hyperthermic. You know what I mean? At least prior.
Sure, but it's going to be confirmed by the toxicology test.
The presence of it. Yeah. So I think we're saying the same thing. It just catches my attention when they're separated out like that, but the title of, or that bullet point is clear. Deaths are driven by this, and that there's polysubstance use. And right. That's why, to me, that's the highlight of this presentation. It's amazing. I think this adds so much to the things that we have, like ODMAP, or even some Mendoza stuff. It's more than just complementary. There's a ton of stuff here that that you have, and as the nuances are learned and things get more granular, hopefully some of those will be able to sort out. But I think that's why this is it again. So thanks.
Yeah. Thanks for bringing some of those points up, Beth, because I think I didn't put this in any slide, but I think a big takeaway from this presentation is to just kind of just get an idea. And then by talking with Heather or Katie, as they ask questions, the kind of things that we should be able to tell you from this data set. And it's going to be specific. So Beth and some clinicians might going to be more interested in granular breakdowns of toxicology testing. You know what I mean? Like, where were the deaths where the xylazines, on board as well. I'll tell you, all xylazine deaths in Minnesota so far always have fentanyl on board too. So, but where are the deaths where there are just meth? Like in Rice County, there are a larger proportion. It's a small number, but a large proportion where they just have meth deaths. But it can be different from one county to another. I mean, we can get more granular with the toxicology with this system because we have everything in there. It's not just what the ME said was the cause of death on the death certificate. It's way more complete, and we can potentially answer questions about specific drugs, and maybe help people tease out interactions, maybe help people tease out things that need to be changed in policy or in systems and other things like that. So I hope one takeaway will be that people will ask themselves, what are the questions I'm trying to get answered? I'm going to email Mary and see if she thinks she can get me an answer when she has more data from this system. So. And then there's I put it in words, so you all see it, that these analyses should be updated the fourth quarter this year with the 2020 and 2021 suitors data. My abstractors are actually, I say my abstractors, but I hold them so dear to my heart because I did a lot of abstracting, and it's a very, very hard job, but I appreciate that I did it because I know the data so well, like I know how things are defined and all those kinds of great things for analyses, but it's a hard job and they're just finishing it 2021 data up this week. So
you will definitely get an email from Katie saying you will come back. No,
absolutely. Yep, that's great.
I just can't.
You might need to arm wrestle with ORAC, but we can't go into that. So
I'm on ORAC. Okay. No, but I think it'll be just great to see kind of what's happened, especially that covers COVID time, that covers the fentanyl coming out. I mean, you'll have to have a data point on the overdoses who also had the incidental COVID finding. I mean, I could go into that list, but I won't.
And I have an intern this summer who's doing an analysis on suitors data 2019, 2020, and maybe the first half of 2021. So the COVID changeover period will be that. And she's looking at naloxone administration and socioeconomic factors. So we'll see what kind of findings come out of that. So fingers crossed. And I plan on the very least to roll her analyses into the larger analyses. It just depends on what happens. But let me just real quick, here are the limitations with suitors, some of which I probably already talked about in depth. So the death certificate lag has been getting longer ever since COVID hit in particular. And, there's less and less resources for the medical examiners and coroners to investigate these deaths. So there's still, for instance, I believe pretty much the first quarter of 2022 overdose deaths are in, but April, May, and definitely June are not in. I did just find out this week that the Office of Vital Records themselves, the National Center for Health Statistics, has changed a bunch of their medical coding. So that's added to like a data lag with the death certificate, and death certificates are what initiate cases into suitors. So the death certificate lag does make a difference to suitors. Case abstraction is very time consuming, and we have employee turnover like many states do. And that can lead to delays as well. The suitors data is not currently available to researchers, and the coding manual is not available online. So I'm pretty much your source for Minnesota suitors. I know, so the National Violent Death Reporting System, their manuals is available online, and researchers can apply for that file. I forget what the CDC calls it, but suitors does not have the equivalent at this time. It's confusing for all of us, probably less confusing for you all, but MVDRS and suitors, they're in the same system, but they have very different timelines. So 2020 MVDRS just got finished in May. 2021 suitors is getting finished this week. So and since they share some cases, not a lot, but some cases, sometimes that adds to the limitations and certainly causes me confusion. And again, I talked about this a lot, right? Is that we can only abstract the data that's there. Just because in my system it says that they didn't have any substance use treatment, doesn't mean they didn't go to treatment, especially out of state or something, or whatever. So we take all our data with a grain of salt, I guess is a way. We know that there could be more, and we're always looking for ways to improve. So the level of detail in suitors, although we're having a lot of circumstances and a lot of history, it still is not comparable to doing a case level fatality review. There's no comparison, I would say. And I'm just going to go to the next slide. This is my information. I'm the only De La Quill at the state, so I'm pretty sure you can find me. Any questions? I know we're getting short on time, but you guys asked such great questions during the presentation.
Well, there's a question coming when Beth turns her video on and unmutes. So, I mean, I hope you know Beth and understand she is like the.
I do know Beth. So I've known her ever since Tara started Mendoza all those years ago.
I guess I turned my video on because it's more of a request
Okay.
than just a question. And I know, again, I'll just say it would be, it sounds like somebody may be looking at, again, administration of naloxone. So the things I think that with, again, a new formulation that's been released, needed or not needed, but just to be able to say, from the information that is obtained, whether it's pre-hospital or hospital, but the strength, the number of doses, but the frequency of administration. And I think that's where, when we talk about or we hear that fentanyl may take more, I'm not comfortable yet for me saying that it's more of an initial first dose as opposed to repeat and subsequent doses. So
Beth, are you talking about the timing of the doses whenever you say that? Okay.
Yeah, we
do not have that information.
Yeah, no, but if somebody's going to be looking more closely at it, because I think the interpretation of what we have so far is that fentanyl takes more Narcan. And I think there's some limitations to saying that, and to say it's really hard, as anybody who's administered Narcan knows, it's hard to wait 2 to 3 minutes if you have somebody in front of you, especially in the out of hospital setting. It's hard to wait. That's the first thing. And that even though, and the other part of it, why is it hard to wait, is a lot of folks who are administering this are not used to. So, I mean, all of this, but it was really just a request, if somebody is looking into this a little bit more, to maybe try and include that.
Not yet, Beth. I mean, we don't have that information. It's not that I would sick my intern on that if I could, but although there's so many naloxone variables in the system, in my system, there is nothing talking about the timing. And I can understand why you would want it, and I absolutely support it. And maybe one of my colleagues in like Cody Bassett or someone, I don't know if he's on the call today, like they might have more information about like the timing of the dosages and things like that. They're trying to get as much good naloxone information as they can. I think the vast majority of the best naloxone information is in the EMS data, which we are hoping to get access to again in the autumn. And one of my colleagues will be analyzing that, because the vast majority of those are people survive. But unfortunately, I wish, I'd like to say yes to you, Beth, but I just don't have that data at this time. But if the CDC ever, gives a timing variable to naloxone, I will definitely have people analyze it. But yeah, there's no way. We just don't have that information. I'm so sorry. I hate saying no to people.
No, that's okay. I'm going to turn my camera off. No.
Well, then the next question would be, Beth, to follow up, if that was even possible, is, well, how many doses did they get of naloxone before they died? And then we'd have to, analyze if the levels even mattered, because they'd be post-mortem levels, and we'd have that whole discussion. That's more of a joke for toxicology. But as far as the
we do know number of dosages. I mean, we asked that question. So
Right.
Oh, you ask it. I'm just saying, I'm just kind of more making fun of Beth at the moment. And Randy Callahan, I'm sorry, Randy, I'm calling you out from, MDH with the EMS stuff you do. So maybe that is a relationship to kind of, what Mary, you just referenced, but. No.
And I just, one last comment, that part again that I appreciated, so correct me if I'm wrong in this, but we're not talking about levels. We are talking about finding the presence of drug or it's negative. And I think the variables that Heather chose to make fun of me about, and the things that it's totally accurate. I think that's a really important thing, is that there's exposure, or we got a negative test, or we have a positive test, we're not talking about levels. So I, again, appreciate that. I think that's an important point.
right. So the system is just really looking for the positive and negatives, but I would say that MEs, when they're determining cause of death and which actual drugs they're going to put on the death certificate, they are looking at those levels. And if they do, like I was just in a fatality review where I can't remember, I think it was Wellbutrin. It was one of the antidepressants, and they had 700 times more than the toxicity level of that drug. So that drug was called out on the death certificate as, cause of death. I can't remember the drug, but like so they were at that time looking at the level. Now, in that case, in suitors, there's nothing about levels. The drug was, the drug was marked present, and it was marked as cause of death, one of the causes of death. But it wasn't until I was in that fatality review that I realized, that I heard the thinking behind of why it was on the death certificate and how extreme, like there was no doubt in that ME's mind that because the level is so high.
When we do our case review things for the maternal morbidity committee, and obviously not obviously, but a lot of our cases have to do with either violent or drug related deaths that we review. And we do have a medical examiner on that with us. And this question comes up a lot for those who, do OB, but don't do the addiction or don't do the drug side. And it's very interesting to hear it from his perspective, though, because he actually always would make Beth happy, because he always says, we can't state that this drug was, or we can't state that this drug was. And people will ask, well, what about the level? Unless you know the exact timing, which you don't, like literally to the second, and got that blood within this certain, they're very good at not giving that level because of all the reasons that we've talked about. So I just find that very interesting that they're very careful with it. Now, a level that's like astronomical, they're like, well, there's literally no other way to get to this level without this, but.
Right. Yeah, I think that's a rarity for me to hear someone actually talk about the levels of the drug. And you're right, people always ask. I don't think I've ever been in a fatality review where they don't ask about the levels. So, yeah. Any other questions from anyone? I know we're kind of at time. I think we're at time.
Yeah, we are. But this was amazing. This was just fabulous. We had Haida on a couple of weeks ago, somewhere since yours and before today, and Haley's on right now, but talking about some of the data and drug trends. And we did get a lot of feedback that was so helpful. And I just feel that this is just hugely important, and it can really give us so much information, especially when we are breaking it to counties and we have people throughout our state looking at the different data in their area and just how important that is. So yeah, Mary, you're gonna get on a schedule. We're just gonna schedule you out
All right, that sounds good. And I had quite a few people reach out to me after my May presentation. Thank you. And quite a few of you, I was able to give you what you were asked for. And some of you I had to disappoint, like I disappointed Beth. And but yeah, thank you so much for just this, having this. It's so important to me to try to get the data to the people who can use it for whatever. Right. And to get to those levels where it will be most helpful. Because when I think about it at the state level, that's only helpful to certain groups of people who are looking at the entire state. So.
And thank you to Annika. She's been active in the chat as well, putting up different links and answering different questions, because looks like Pennington County and my home county aren't even on the list, but she did reassure us it's coming. So I just thank you, Annika, for watching that and giving the links as well. All right, everybody, thank you so much. Next week, schizophrenia and substance use disorder. So we're going to flip totally different sides, but it'll be awesome. So have a great day. Thank you.
Thank you.